We are pleased, honored, thrilled about having Dr. Ann Harrison come and speak to us. Just a little background on Dr. Harrison. She got her BS from Center College in psychology, and then did some post-bac work at Louisville, and then received her PT degree at Indiana Central University in Indianapolis, and her PhD in gerontology from the University of Kentucky. Looking through her curriculum vitae, she serves past and present on numerous university, professional, national committees. I could go on and on and on. She currently is an associate professor here at UK in the Division of Physical Therapy, and she's director of professional studies in the Division of Physical Therapy. I know many of you have talked about or are contemplating possibly physical therapy school, either applying here or at other institutions. So I think you'll enjoy this presentation live. Thanks.
Thank you, Dr. Facey. Well, it's nice to be here. I told Dr. Facey when she asked me to come, I said, well, now this isn't right in the mainstream of exercise physiology, but you know, she said, she assured me that you all were open and broad in your thinking, that kind of thing. And I was thinking about it and thinking, well, really and truly, most of us who are clinicians really are very translational in our thinking. And so when you're studying biomechanics and you're studying muscle physiology and you're studying exercise, you know, ultimately you're thinking about, you should be thinking about how people are functioning in the world. So this is really about the experience of people who have had stroke. And we were really focused on people who are in rural Appalachia. We did happen to get a grant to help fund this study and some other work that we've been doing, but it's all focused in rural Kentucky. And you may have heard Pat Kitzman come and talk about the Kentucky Appalachia Rural Rehabilitation Network. This is part of, Pat and I work together, and this is part of the work that we're doing. So this is going to be our project that we did called the Needs Assessment of People with Stroke, and it does include their caregivers, by the way, in rural Kentucky, rural Appalachian Kentucky to be specific. We had a really great team of, an interprofessional team. Interprofessional, you know, is a great buzzword right now, but it's true. This is a very interprofessional group. So we had speech therapists who are working on their PhD. We had a nurse who was the director of rehab at ARH, Appalachian Regional Healthcare, which is a big multi-institution healthcare throughout rural Kentucky. We had Janice Cooperstein, who's on our faculty in physical therapy, Megan Danzel. So we had PT. Oh, Beth Hunter is the director of research at Cardinal Hill, and she's an OT. So we had a lot of professions represented in this group that was coming together to do this needs assessment of people who live in rural Appalachia. So basically, I could give you a lot of numbers, but here's the bottom line. Stroke is a huge problem in Kentucky. There's a lot of people who have stroke in Kentucky, and there's a lot of people who are disabled from stroke in Kentucky. We are, in fact, in the stroke belt. There are 11 southeastern states that are considered the stroke belt of the United States. These are states that have very high incidence of stroke. But guess what? Kentucky, and specifically Appalachia, Kentucky, is right in the buckle of the belt, meaning we have the greatest, okay? So 26 Kentucky Appalachian counties have the highest incidence, this is from CDC statistics, of stroke, and stroke leads the causes of long-term disability. So we know stroke is a huge problem in Kentucky. We think these are some of the reasons why. There's research, of course, looking at why is Kentucky having so many health problems, especially in the rural areas. Socioeconomic status, you know, education and income always fall out, always, in terms of health predictors. So socioeconomic status matters. Access to medical specialists matters. Multiple chronic comorbidities are all, these are all factors that contribute to increased incidence of stroke. Of course, the big chronic comorbidities that are associated with stroke include diabetes, obesity. Okay. Smoking is, by the way, a lifestyle factor that contributes to stroke. I was just listening this morning to, I believe, all of Kentucky. They're thinking of passing a law throughout all of Kentucky that prohibits smoking in public places. I'm sure there'll be a lot of resistance. Okay, so there is some work on stroke in rural communities. There's not been much done in Kentucky, but when you look at the literature, you find that there's been some done in Wyoming. There's a big rural health network out west. There's some good work out of Australia. There's a little bit of work in regards to the rural African-American communities, particularly in North Carolina. And these are the things that pop up in these rural communities as being problematic. There is a lack of access to health care, especially in terms of specialties in stroke, like neurology, for example. Depression seems to be a factor. Multiple comorbidities, as mentioned earlier, a factor. And then one of the things that we find in rural communities, more so than in urban communities after stroke, and the younger stroke patients is an inability to return to work. So what we found, of course, no surprise, was that there really was a lack of information about people in rural Kentucky who had stroke. So we really did set out to figure out what were the experiences of people with stroke in rural Kentucky. Now, it helped us to have some funding from NIH. We had already started down this road when the American Recovery Act money was out there, and we were able to get a really nice grant to support not just this work, but some other work that we were doing with Karen, and I think, when I say Karen, I mean Kentucky Appalachian Rural Rehab Network. But my focus here was on the area of stroke. So this is the needs assessment for people with stroke. We call ourselves the NAPS group. And the purpose of the study was to describe the lived experience of stroke for survivors and for their caregivers, because the other big issue is what's happening to the caregiver for the person who has stroke. It's a very humongous commitment, and caregivers have health issues as well because of the stress that they face. We started out with a needs assessment because anytime you're trying to develop interventions, which is what we really want to do, is get to an intervention study, you really kind of have to figure out, well, what's going on first. So we decided to go for a needs assessment for starters. And when we looked at this, we were like, well, how do you do a needs assessment? We can find out how many people had stroke. We can find out what their comorbidities are. We've got a big database now, we didn't at the time, that can tell us a lot about these folks in terms of data. But what we didn't know is what their personal experiences were. We wanted to hear from them. So that dictated a qualitative approach to our research methodology. So we went for a qualitative approach, and in order to do that, for this team to do it, we really didn't have, some of us had some experience in qualitative, but we weren't profoundly experienced in qualitative, so we had to actually have a journal club that met for a whole semester first, where our team came together and really worked on, got us all up to par with qualitative methods. We don't like to say a study's not qualitative or quantitative so much as it is the question dictates the type of methods that you need to use, and our question really required a qualitative approach. We had some formative theories and models that initially, some of this drove us initially as we were thinking about what we wanted to do, and then ultimately we ran into another model or two that helped us to formulate our codes and themes as we went along with data analysis. So I wanted to tell you about the models that we have really settled into that drive this organization of our study. The social ecological model, the self-determination theory of health behavior, and then this constructs related to social support. These are the main things that I'm going to talk about in the context of our patients. This is the social ecological theory of behavior. Now, you are in exercise fitness and biomechanics, but you're in KHP, so theories of health promotion are probably not new for most of you, am I right? And this actually isn't a health promotion theory so much as it is a broad theory of behavior. And it's a really nice theory to be utilizing if you are getting ready to develop a study, because it looks at, on the broadest sense, what influences the behavior of the individual. So the individual is in the center of these spheres, the microsystem, if you will. And you have the mesosystem, which really represents the relationships of the people in the microsystem, the individual. You have the exosystem, which is the community, healthcare, etc. And on this more formal model, they have a macrosystem and a chronosystem, which really gets at the culture, health policy, and other kind of broader, more abstract components that affect the individual. So this gives you a nice model if you're trying to come up with a study that's really looking at behavior, and you can kind of figure out where your factors lie as you're looking at this. So this was our broad formative theory or model. Now this was, the self-determination theory is what we use to look at the individual. So we had the broader theory of social ecological, looking at the factors outside of the individual. And then we were trying to figure out, well, what's driving the individual in terms of outcomes. So we settled in on this self-determination theory, and I really liked it a lot. It's really about what drives us, or what are we seeking, what are we trying, what is our outcome that we're hoping for when we're adopting new behaviors. And it has a lot to do with health-promoting behaviors. What motivates people toward health-promoting behaviors? In this sense, we're talking about not just physical health, but emotional and spiritual health as well. You know, all domains of health. And there's really three main factors that play into this. And I'm kind of spending a little time here because when we get to the analysis, I've got it organized based on self-determination theory. The factors are autonomy, which is being a causal agent in one's life. Relatedness, which is trust and desire in interacting with others around you. And then competence, which is your ability to feel capable and competent to handle situations effectively, what you've probably heard of as self-efficacy in the health promotion role. So I want you to remember these three definitions because we're going to use them to really organize our data analysis. Autonomy, relatedness, competence. Three factors that influence a person's motivation toward health-promoting behaviors. And so this sort of became our formative model as we were analyzing our qualitative data. Has anyone in here done qualitative research before? So some of these constructs of how you do qualitative research are going to be new for you, okay? But when you do qualitative research, you have a lot of data that is all about interview data. And you're trying to put an organizational structure on that data based on themes that you see. So you really do rely on theories and models to help you develop the organizational framework. So here we have in the blue, of course, the social ecological model. We have self-determination as the output for the individual. And we have the support constructs. What kind of support are the individuals receiving after stroke? And how do those supports, whether they be assets or needs, influence their autonomy, competence, and relatedness? These are our methods. Was a team approach, qualitative. We had to develop the interview instrument. We started really right from the very beginning here, after we did our journal club on developing qualitative methods. We had to get IRB approval, of course. This was really fun because we had 3 institutions we had to go through. If you've ever gotten to do that, that's a great experience in busy work. So we had to go through UK, of course. We had to go through Cardinal Hill, IRB, and then we had to go through ARH, IRB. So I spent a lot of time, in meetings, and they all have their own process, I might add. So you had to fill out paperwork, cut and paste into 3 different IRB fabrics, if you will, to get your project approved. They were ultimately approved. It wasn't, there was no risk here really, but it still was a pretty big deal to get it all done. We did recruit by utilizing the data lists of people who have had stroke and who have received rehab at one of the Appalachian regional hospital facilities and or at Cardinal Hill. And they were able to sort out in the last 5 years hundreds of people who live in rural Appalachian counties who have had stroke. So we sent out letters of invitation, and this was a great learning moment for us because I thought we'd get a lot back, but we didn't. We got a trickle-down effect of some people sent back willingness to participate, and they knew friends and that kind of thing. So recruiting was a big deal. We really, getting people who live in a very rural area to be interested in being part of your research study, who have had a stroke, and they're usually older, was not an easy process. This was our inclusion criteria. They needed to have had a stroke in the last several years. Now, we were looking for people who had had stroke at least 6 months ago. We preferred a year or 2 years out, because what we wanted to know is, what was it like when you went back home and tried to reintegrate into your community? What was your quality of life? Not just the person who had stroke, but for the caregiver as well. They had to be at least 18, ability to participate in a 60, 90-minute interview. That really gets at their health, their endurance, fatigue issues. English speaking, and then they had to be a rural Appalachian resident. Now, there is a definition of rural, formal definition. If you ever are going to be doing research in this area, this is a good thing to know. The field codes are a continuum codes for, here they are, for rural to urban. And so if you're trying to make a case for research in rural or urban areas, it's good to know about the field codes. So you can see that 1 is urban, really, metropolitan areas of 1 million population or more counties. And 9 is completely rural. I, by the way, live in probably an 8, a 7 or an 8. I'm about an hour from Louisville, 1 hour from Lexington. All of our counties, for people that we had in our study, were in the 7 to 9 realm, meaning that they were really very rural without very much in the way of population. So here's how we did our data collection. I come primarily from a more quantitative background in my research methodology, so I really wanted a quantitative instrument. I just had to have one, you know. So everybody's like, okay, we'll put one in there. So we used the stroke impact scale. Now this is a really nice quantitative measure of how much the stroke has affected your ability to function in the world. And there's lots of great psychometrics on it. So again, if you're going to study stroke, it's a nice instrument to use to give you an overview of how the person is doing in terms of function. And I'll show you the scores of our subjects. It didn't end up being a key player yet in our data analysis, except it characterized our subjects really well. We had a very diverse group in terms of their ability to function in the world. We did semi-structured interviews. We had to develop the interview instrument. These are called qualitative methods, open-ended questions, where you ask a question, and the idea is not to ask a question that has a short answer. The idea is to ask a question and let them begin the process of telling you about their experience. We used metaphor, so all of our subjects answered the question, living with stroke is like, and then they answered that question. Oh, and of course we got demographic data on everything too. So this is just a sample of the questions we asked. These are all ones that, believe it or not, it took us a long time well, there were 6 of us, so usually 7 actually. So it took us a long time to come to consensus on what questions were really the ones we wanted to know. But this gives you a good idea. Now what we really ended up trying to do was find out from the person, get a retrospective view of what happened when you had the stroke. Tell us about that. What happened in acute care? What happened in rehab? What happened after you went home? So we really wanted to know across the continuum of care, what was their experience? Ultimately, we were trying to get a handle on what was their community reintegration like, and what were the barriers to that reintegration. And in understanding that, we hoped that we could start to develop really a prioritized agenda of research that might help us increase support for people with stroke in rural Kentucky. This is kind of a busy slide. I won't read it all to you, but it's just to say that when you're doing qualitative methods and you have a team like we had, after you do your interviews, get them transcribed. There are 100 pages each, by the way, so there's a lot of data in those interviews. And you're having people read them who are part of your team and coming up with codes. What are the codes or things that are falling out that seem to be fairly important in this particular interview? And the continuum of care certainly was one of the organizational themes that we had. Things related to emotional health, caregiver fatigue, fatigue of the person, themselves with their life and with getting around in the community. These were examples of codes that kept falling out for us when we analyzed the data. And in order to try to make sure we were being trustworthy, that's a word in qualitative research for valid and reliable, we had always had 2 people involved with every analysis. In the beginning, we had all 7 people involved, and we all did 3 interviews completely together. And we met 2 or 3 times to come up with what we thought was a valid coding scheme for those interviews. It's a very intensive process, I might add, and you actually argue quite a bit on purpose so that you can challenge each other on, is that what they meant, is that what you saw? Ultimately, we had an organizational scheme for analysis that we all agreed on, and then the interviewers, the 3 people who did the actual interviews, went back and coded their interviews by that organizational scheme. And then we had somebody check that person's coding to see if there was agreement. So these are some of the terminologies that you use in qualitative research to make sure that you have a valid approach to your analysis, that you have a reliable approach. Trustworthiness and credibility are 2 big components that were really dealt with in our study by the team approach that we had. So we had 13 people with stroke and 12 caregivers that we interviewed. And you can see where they were from, these various counties in rural Appalachia. This is where the counties reside on that field code, that rural-urban code that I showed you. Basically all very rural. We just put in economic status to make the point that all of these counties that people are from are considered distressed counties economically. And there's a lot of good data about each of those counties. This is just showing you on a map where the people live that we interviewed, rural Appalachia. This is, by the way, rural Appalachia, Kentucky. Everything in the gray. I'm sorry this slide's too many small numbers as well, but it really just gives you the demographics of our subjects, both people with stroke and the caregivers. And you can see that we had more females than males in both the stroke survivor as well as the caregiver. We had a pretty constant ethnicity, all Caucasian. We're in rural Appalachia, which really has a low presence of minorities. Years post-stroke, average year post-stroke, 3.6. So we were seeing people who'd been home and trying to live with the effects of their stroke. We had 6 people in the caregiver role. We had 6 people who were the spouse, 6 people who were the child, the son or the daughter, giving care, the primary caregiver for the person with stroke. And we have a pretty diverse educational background, pretty diverse income background, and then the marital status is also diverse. Now, this is the stroke impact scale. If you ever want to use the stroke impact scale, call me, because I've got a lot of data on it in terms of how you score it, the validity, the reliability. It's a very well-researched instrument. I like it a lot. Basically, these are our folks over here. They all have code names, by the way, ones they either chose for themselves or we chose for them. Sometimes we use initials, but everybody does have a code name. These are the domains of the stroke impact scale. And I'll kind of turn your attention over to this overall rating of recovery. Now, on the stroke impact scale, the items run from 0 to 100. 100, it's really a percent of ability. So 100% means you don't have any problems. 0 means that you can't do it at all. So you'll see on this overall rating of recovery, one person felt that they were 100% recovered. We didn't, by the way, think that, but this was her rating of herself. And I might add, she was the one person who had an incredible family support system. We had mostly people who were all over the map in terms of how they viewed their percentage of recovery. If you look at various domains, you see strength over here. These are several items that come together to make up the strength domain. And you can see that in this case, Juanita felt like she only had about an 18% recovery of her strength. whereas really nobody felt like they were 100% back. So there's a lot of strength deficits left in these folks who have stroke. This is self-report. But I like self-report because self-report tells you what they actually do, even though physical performance measures tells you what they can do. But self-report tells you what they do. They're kind of different domains of function. They're slightly overlapping, that's what I'm doing there. Physical performance tests versus self-report. They're overlapping, they correlate maybe 0.4, 0.5, but they are different, measuring different things. If you look at communication, we were really interested in communication because when you have a stroke, especially on the left side of your brain, oftentimes you're left with aphasia, word finding problems, and communication, as you know, is really integral to community reintegration. And we had some speech therapists on our team, so they taught us a lot about aphasia and communication and how it limits your ability to reintegrate in the community. And you see on the communication, people were doing pretty well, which is probably one reason why they volunteered to be in our study. But here's one, for example, very low recovery in communication. Now, one thing that was interesting about communication was our speech therapists who listened to the tapes said, oh, that person has dysarthria, difficulty articulating, but that person maybe did not identify that way. That person has aphasia, word finding problems, but they may not have identified that. And there are strategies to help with that, but the person may not have received speech therapy to address those strategies. Bottom line for this data is that our people were all over the map in terms of their recovery, emotionally, in terms of strength, in terms of mobility, getting around in the world, and in terms of their upper extremity function. This person, Juanita, she had zero function in her dominant hand after her stroke. This person, two people down here, zero function in their dominant hand. So you can see these were people who had quite substantial impairments. And these were years after their stroke. Okay, so I wanted to give you now, I want to jump into some of the data analysis by using quotes and actual verbatim information from the subjects. These are, anything that's in black and italicized is a verbatim quote, okay? So these are the metaphor that we use, the data from the metaphor. Living with stroke is life. And the best, if you read through these, what you will see is that there wasn't one person who didn't say it was a very, very big deal in their life. In fact, we have a paper that's getting ready to be published in the Journal of Rural Health with this data, and we named it Living with a Ball and Chain, the Experience of Stroke in Rural Kentucky, because this is what really a lot of people felt like. Experience of stroke, living with stroke is like living with a ball and chain. One person, a daily adventure. I like that, a little more positive. Uphill battle, seeing with different eyes, like being invisible, and then this person felt like her life had been shattered. So it's a big deal. So we organized our data analyses across the continuum of care in terms of the person's retrospective view. Now, I'll start out by telling you a little bit about their stroke onset. We asked the question, tell us about the stroke. What happened when you had the stroke? And then we just let them talk. And the caregiver then gave us their version of what happened with the stroke. It's very interesting. Almost 2 to 1, they did not know they were having a stroke at the time they had the stroke. One of them, actually, her brother is a physician, and she lives pretty near Hazard, which has a lot of great medical care. And she called her brother, and he said, oh, you're probably just having a bad day, lie down, take it easy. Then the next day, she called him again. He said, well, give yourself another day. So on day 3, she started being unable to speak. Her stroke was expanding, and that's what happens with stroke is it will start. And if you don't do something to really curtail the expansion, it can expand and get worse and cause more damage. So the fact that they didn't know they were having a stroke really resulted in their inability to get immediate care and get TPA, tissue plasminogen activator, and there's another one out there now. TPA is what they're using in the emergency room in the first 3 hours after the stroke begins. But there's a window of opportunity, and TPA stops the expansion of the stroke in a significant number of people. It's a good thing to use. But you can't use TPA after 3 to 4 hours, because then it has a reverse effect of causing more damage. So you have to get there right away. Now these folks are in rural areas. So a lot of them do have a hospital that's close enough that they could have gotten to a hospital within the first few hours if they had understood the signs of stroke. And these folks had profound signs. You know, they couldn't speak, they couldn't walk, they were, you know, they fell down, they had paralysis on one side of their face, they couldn't lift their arm up. You know, it's really a testimony to how we need a lot more public health campaigns to educate people about the signs of stroke. Now, even in Lexington, we don't do a very good job at it. In Louisville, they actually have got some great billboards all around Louisville. So you see the urban areas get a lot of attention, but it's the rural areas and even Lexington that we haven't done a very good job of educating people about what the signs of stroke are. And so, of course, what happened was caregivers felt so guilty because they didn't immediately understand that this was a stroke, I need to get them to the ER. And so the caregiver burden was pretty huge in this regard. I beat myself up for not having known it sooner. I'm thinking that of about 5 people that I remember that actually waited about 2 days to get to medical help because they didn't want to bother their children, or they didn't, you know, they just were thinking, I'm just having a bad day. The other kind of interesting thing, and I don't have any profound thoughts about it, but for most of these folks, it was their first time ever flying, and they were flying in the helicopter to UK. So once they got to the ER in their local area within those first few days after the stroke started, then the ER doc said, we got to get you to UK, to the ER, and the stroke center here. And they came to UK, flying in the helicopter. No family members allowed the helicopter, I might add. So they're in the helicopter, first time flying, having a stroke. It's kind of interesting, but none of them said, oh, it was terrible, I was so afraid. I mean, they do remember the helicopter ride. So now they're in acute care. After they get to the ER, they go to acute care, and none of them remember acute care, hardly at all. So there's very little to no memory of the acute care setting. And that's an interesting thing to remember for those of us in rehab, because we try to educate people in acute care, right? If we're in the acute care setting. But nobody can hear what you're saying in acute care. You may teach them transfers, you may teach them how to use an assistive device, they're not going to remember. They're worried about living and dying at that moment. Something big has happened. Life has been turned upside down, as one of our subjects said. The other thing that happened was, you know, in the medical world, you're used to seeing things that are really bad. So if somebody's having a stroke, there's a tendency to minimize what's happening. It's just a small stroke. And 3 or 4 of our subjects said they were told it was just a little stroke, just a small stroke. And they all said, well, it may be small to them, but I couldn't speak. It was huge to me. And the caregivers were, you know, very distressed. So they really were upset that it was oftentimes minimized, which then conveyed expectation for a full recovery. And that's a problem, because none of these people really had a full recovery. Most of them were still fairly disabled by the time we met them. So I wanted to just say, in the acute care setting, I used some quotes here to show you, give you some perspective on how people were feeling about their autonomy, their ability to relate to others, and their competence. Now, as you might expect, in terms of their autonomy, they were feeling totally out of control of their lives, understandably. Competence, they were feeling like they couldn't do anything, especially if they'd lost their ability to speak, they'd lost their ability to walk. So competence was way down, autonomy way down. What was important to them, most important, was relatedness. If they had one person in that setting that they thought really cared about them, that mattered. And they remembered that in the acute care setting. So this is Columbo talking about, that's a podium, talking about a speech pathologist that she just reached into his soul. Because she understood what was going on. It was very touching talking about it. I want to say that a couple of people felt like they were released from acute care too soon. The hospital people were saying, you're fine, you can go home. And they were saying, no, I can't talk. You know, I can't walk very well. And they were afraid to go home. So, very low autonomy, very low competence, dependent on relatedness. And in some situations, they really didn't feel like they were getting very good relationships. And this is an example of that, where the doctors were bringing in a lot of students. I don't think they really brought in 800 students. But the doctors were bringing in a lot of students at UK to see. And this guy, in this case, Samuel, had some unusual paralysis of his face. So they were coming in to look at his paralysis. Yeah.
Do you think this, the feeling that they're getting is different in rural than it would be in a...
This is, at the end, I'm going to say what we still need to do. We need to compare it to what's happening in urban areas. So this is, all I can talk about really is rural areas, but we actually have a project where we're interviewing people in the urban areas, and we're going to look at the data and try to compare them. Now one thing, and we've already done 8 of those interviews, and one thing that's sort of falling out is the time to care. The time to get your acute care is less in the urban area.
Yeah, but I was just kind of wondering in terms of how these people are relating to the stroke and the signs and symptoms themselves, whether that would be any different.
It's probably very similar,
okay.
Urban and rural, probably very similar. Okay, so we talked about stroke onset, we talked about acute care. Now let's talk about inpatient rehab. That's like Cardinal Hill, by the way. And ARH, Appalachian Regional Healthcare, has inpatient rehab. This is where you go for 21 days of free care. 21 days that Medicare covers 100%. After that, Medicare covers 80% if you're still eligible for up to, I think, 90 days. Okay. So it's first of all, let me say they were all kind of bummed out about having to go to inpatient rehab because they were hoping they'd go to the hospital and be cured and go home. So now the journey really begins. They go to inpatient rehab, and it's a profound time of recognizing what had happened to them. They're starting to understand something's really changed here. I'm going to have to deal with this. The support, there was a lot of great support in inpatient rehab. There's a lot of great support in acute care. And what you find in all of these is that everybody's feeling pretty good about their acute care and their inpatient rehab. They've got a lot of support to keep them up while they're going through it. The caregivers of these folks oftentimes live 3 hours away if they had to come to Cardinal Hill, for example, or ARH, or Pikeville has a great, with Carl D. Perkins has a rehab unit as well. But if you had to travel a long ways and you wanted to be with your loved one, those caregivers were fatigued. They were worn out. They drove every day to see their loved ones, or they maybe stayed in a hotel so that they could go see their loved ones every day. So I'd say in terms of inpatient rehab, the people that probably had the worst time were the caregivers, because there were a lot of people rallying around the person with stroke. And the person with stroke had very positive views of their caregivers, of their rehab team. They called Cardinal Hill the Mecca of stroke care. The sunshine in the darkness. You know, these were people who were saying, the rehab specialists are saying, we're gonna help you find your competence. We're gonna help you find your autonomy. They're really, I think, leading people in the right direction. And these are some of the quotes that I pulled out that kind of represented the inpatient rehab aspects of autonomy. They were helping put me back together again. And this person felt like that they really were looking at the individual down at the deepest levels. This person I wanted to put this in so that you could see, I just kind of went through the realization of what really did happen to me. So inpatient rehab, there's a lot of realizations that begin to happen. In terms of competence, they loved it that the OTs and the PTs were having them do things that they were going to do when they go back home. Hanging clothes on the clothesline, if that's what they do. And we're really trained to figure out what do you do when you're at home, and then to try to incorporate that into therapy rather than just exercise. It's a functional approach to exercise. In terms of relatedness, most of the people really had a strong trust and relationship with the people in inpatient rehab, but the caregivers were feeling left out because they were traveling, they were exhausted, they couldn't be there every minute. And so I'd say the caregivers had the worst time with the relatedness issue when it comes to this aspect of inpatient rehab. Okay, now we're going to talk about home and community. Now, three of our people didn't go home, they went into nursing homes. Nursing homes in their home, community. So we call that going home, but they're not going home to the house they lived in beforehand. So here's what's happened. These folks have great support in acute care, great support in inpatient rehab. They go home and all the support begins to dwindle. And you know, that's what you would expect, probably true for urban as well as rural. But urban folks have resources much closer by. And rural folks are living down a holler in the mountains. So who do they depend on? They depend on their caregiver, they depend on their church, they depend on their neighbors. And usually people did rally around them in the first week that they were home. So these were things that we found. There's a lack of confidence in local health care providers in rural areas. So it isn't that there isn't good health care in rural areas. It's that people were thinking that the only place they could get their outpatient PT was Cardinal Hill. That's the Mecca, right? So they were driving 2 and 3 hours, 3 times a week, one way, to get PT at Cardinal Hill when there were really very good PTs in rural areas. So one of the things we like to say is that there's a lot of well-kept secrets in rural Kentucky in terms of services. People need to find out about them. So that's part of what Karen is doing, is really trying to map out the assets of the individual communities around Kentucky, of which there are many assets, but people who live there don't even know about. A lot of them had trouble with understanding their insurance coverage, their financial support, that kind of thing. Those were issues. Now I broke out the 3 domains separately for this area, the home and community reintegration, because this was the area we were really focusing on. And so you'll see some of the things that people said in terms of their autonomy. They're scared when they go home. They're very scared. They can't get up their stairs as soon as they get home. Oh, their wheelchair doesn't fit down the hallway because the hallway's too narrow. One of the guys I interviewed, he went home to his home, which was a mobile home, and the hallways were too narrow. So he went to his daughter's for his wheelchair. So he went to his daughter's to stay, and her bathroom door was too narrow for him to get in. So it was one kind of problem after another, just in terms of his wheelchair getting in and out. Those are really disabling problems. So a lot of people, here's a example of being devastated financially. A couple who were really close, they had big plans in retirement, and of course, you know, they were devastated with the financial aspect because they could, now all their plans were really going to have to change. In terms of competence, there was a loss of meaningful roles, and people talked about that. Previous goals could no longer be met, like the traveling we were talking about with this previous couple. And then they just didn't have enough information. So they may have had a lot of training on how to do transfers at Cardinal Hill, for example, or in acute care. But when they go home, everything starts over again. It's kind of like you're starting over from zero, and there's nobody there unless they're getting good home health, which some of them did when they get home. But some of them didn't, and that was in part because of insurance issues. The caregivers were feeling very fatigued. They started to realize, hey, if I'm not rested, I can't help this person. So relationships change a lot. I had a person who did not get to inpatient rehab. She just got discharged from the hospital and went home because it was a mild stroke. And she had some aphasia problems and memory problems and thought she was going crazy. Her husband thought she was going crazy too. And she had a rehab center just down the road that really could have helped her 2 miles away. But nobody got her connected to that because they just didn't know. And she was maybe 62. So, you know, you can go to work at Goodwill. That's what this one guy was told. He had an degree in business management. And he was like, you know, I don't want to go to work at Goodwill. I've got a degree in business management. Now, there were some people who were trying to rationalize it. In this case, this couple, where they felt like God kind of had a hand in the stroke because it caused her to have to stay home and take care of the child at home instead of working. This was a younger person who had a stroke. So they sort of rationalized that God works in mysterious ways. And there's probably a whole study here, I'm sure, on coping mechanisms, but I don't have time today to get into all that. Then the last thing is to say, in the domain of relatedness. Now, what do you think about rural Kentucky? How many of you are from rural Kentucky? Okay, so we have a stereotype that we're Eastern Kentucky. We pat each other's back, we help each other. This is what one of the subjects, I think the subject told us. And then this person, my family stepped right in. They're a great bunch of people. So you tend to think large families close by, they're gonna help out. And in fact, they do in the very beginning for about a week. And in some cases, that stereotype remains, but in most of the cases of the people we were interviewing, the stereotype did not remain. They actually ended up being isolated from family and from friends ultimately. In part because of a lack of knowledge, people were fearful, they didn't know how to relate to somebody with stroke, and maybe the person was too proud to really reach out and ask for help, the person and the caregiver. So there was much more isolation than we thought there would be. We went in thinking that the rural families would be much more supportive, and I suspect that's just because we had a stereotype. Most people lost most of their friends. And then I wanted to say they had a lack of trust. I mentioned that earlier about the rural community. Drug addiction in the rural community is such a huge problem, and a lot of these folks are on medication, so they were afraid to have hired caregivers come in because they were afraid they might steal the medication and sell it. So, and that's probably true urban or rural, I'm sure. So, I just wanted to go back to our model here and say, one of the things we were really looking at all along was what kind of supports people had throughout the continuum of care to help them in this area of self-determination. And this is a summary of kind of what we saw in terms of supports. The emotional, spiritual support, once they've gone home, is there in the beginning. Church, where everybody from the church brings food, families are there, and usually neighbors will have built ramps. I mean, people help people. But then after a couple of weeks, everybody goes back to their own life, and they're not quite sure how to help. And that's what we found to be true with the people that we saw. Appraisal support is somebody saying how you're doing. You're recovering pretty well. You're doing pretty good. Or I've had a stroke, and this was my experience. And comparing notes, that's what appraisal support is. Most of the people that we met, all the people we met, didn't know other people with stroke. So the caregivers weren't communicating with other people who were giving care, and the people with stroke weren't communicating with other people who had stroke. And that was a loss for them, we felt like. Informational support, they needed more information on signs of stroke. If you have one stroke, you're much higher risk of having a second stroke. Most people did not know that we were interacting with. Lifestyle issues that contribute to stroke, they hadn't had much information on that, and then healthcare access in terms of information was sometimes a problem. So these are other areas of support that we found to be lacking. The environmental piece was huge. They lived on the side of a mountain. Their driveway was like this. Their car's at the top of the hill. How are they going to get to the car and get in the car to go where they need to go? It was just a very difficult, environmentally, a difficult problem. Transportation is a huge issue in the rural area. So these are recommendations that we made based on the things that we found out. And these are all things that just need a lot more research to be looked at. But one thing about a qualitative study that's really nice is it doesn't answer your questions necessarily. It gives you rich descriptions. It helps you prioritize your research. It helps you ask questions. So it really tells you what are the questions we should be asking. And these are some of the things that we are now already working on in the care group as we set up our priorities for how we're approaching folks with neurological impairment in rural areas. We've done the same kind of needs assessment with people who have spinal cord injury, and we're in the process of doing this with people who have brain injury. So we'll have information regarding all three of these, people with all three of these various pathologies. So this was the final model we developed that we are kind of needing to test out. We've submitted some grants to get some funding for this, but this is the microsystem. We just really went with the microsystem and the exosystem and the mesosystem. This is the person and the caregiver. So at this point, the individual is not by themselves in that center. It's the individual and the caregiver that are in the microsystem. And the exosystem are all these external community healthcare and that kind of thing. But we've redefined the mesosystem as being the integral person or institutions that really bring together or integrate the microsystem in the community. So this might be a community health navigator, a case manager, a PT, an OT, a rehab professional physician, but everybody needs to see themselves as doing this, not just as being on the outside, but as helping people integrate. And we've got a lot of good data on how, or I should say recommendations on how to do that. Of course, there are limitations. Qualitative study gives you a lot of depth, but not a lot of breadth. And as we were talking about earlier, this comparison to urban, we don't know, we suspect where some of the differences are, but we don't know precisely until we really evaluate our urban data, and that's underway right now. And then this is our future work that we're working on. We did a needs assessment of healthcare practitioners. We did a quantitative survey with people who work with people from rural areas to find out what they know about the rural area and what the needs are. So that's kind of underway as well. We're writing a grant right now with the PCORI group, the national grant, looking for ways to engage people in rural Appalachia in research. And it's really very challenging. All right, I think I've done just 3 minutes time. I know y'all probably have places to get to, but are there any questions? Do y'all have 10 o'clock classes? Oh, okay, good. Any questions? Yeah.
Noticed, sample size was a problem there. Is there anything that you've learned doing this? Any insights in tackling, a population like that? And also, how many questionnaires did you send out?
Well, we went to the home. We went into their home. We interviewed them. We taped the interviews and then had them transcribed. So, how many did we? How many?
Because you obviously sent out questionnaires to see if they were interested.
We placed them out to the
Yeah.
Yeah. So we ended up with about 20 to 25 people who contacted us, and for various reasons we ended up with that sample size. So that's kind of how it is when you're looking for people with brain injury. We're doing that now with people with brain injury and spinal cord injury. What we want is we would like for these folks to become part of our caring group, and then they can inform us about our priorities and research agenda and that kind of thing.
And do you have contacts now in those rural areas that might help with recruitment?
Oh, sure. And actually, one of the members of our team is the director of rehab for Appalachian Regional Healthcare. We've got a program at the Center for Rural Health and Hazard, and they help, and they have a family medicine clinic. They help us as well. But again, and they all did help us actually, but it's challenging. Yeah.
You might need to have
Yeah.
quantitative data too.
Yeah.
Do you have like the medical files on the people? So I think their perception of how they integrate or what their experiences were are incredibly important.
Yeah.
But are you matching those up with truly the severity of the stroke or the different types of stroke? Or
We know the side of the stroke, of course. I mean, we were able to tell a lot of things just by interacting with people. And most of us, because of our work in rehab, understood where they were functioning in terms of disability. The stroke impact scale really gives you a lot of information about that. And then we describe them. So yeah, we've got information, but it's observational. We didn't have access to charts. HIPAA is very, that was the big thing with ARH and Cardinal Hill is, you can't see anything about these people. Now, what we would love to do sometimes is have a longitudinal study where we start. In fact, our last grant was submitted to was a grant where we wanted to connect with people as soon as they have a stroke at UK in acute care, and then follow them along till they go home or through the first year of their stroke. That's what we really would like to do. And then we would have lots of great data, very rich data. This is really a retrospective kind of cross-sectional view. But a longitudinal view would be a gold standard for this, for sure, following them along. Well, I know some of you need to go, so I'll stick around if anybody has questions. And thank you for having me.